still don't know what I was waiting for. And my time was running wild, a million dead-end streets. And every time I thought I got it made, it seemed the taste was not so sweet. So I turned myself to face me, but I've never caught a glimpse of how the others must see the faker. I'm much too fast to take that test.
At the very end of residency, I had the case, and many of us have the case in our careers, right? The case that is the most impactful, the most traumatic, that you've experienced. And for me, this was a 3-year-old little girl who came in unresponsive. I had a child the same age at home, and we tried to resuscitate her, could not. I comforted her mother and talked to her, and if that had been the end of the story, it would have just been one of those cases we all carry, right? What's the quote? Every surgeon has a graveyard, right, that they visit. But a few weeks later, I was called to testify in the murder trial of that little girl, and her mother had killed her and was convicted ultimately. And I was so angry, Lee. I was angry for that little girl. I was angry for something that I lost in that experience.
Change the size, but never leave the stream of warm permanent sand. So the days float through my eyes, but still the days seem the same. And these children that you spit on as they try to change their worlds are immune to your consultations. They're quite aware of what they're going through.
Hello and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I am your host, Lee Scheinbart, and this podcast brings you the hottest and most crucial conversations in healthcare and physician leadership. Today, it is my honor to dedicate this episode to Dr. Lorna Breen and her family. Dr. Breen, a well-respected emergency room physician at New York Presbyterian Hospital and recipient of an executive MBA in healthcare leadership, led her emergency department during the initial COVID-19 surge at one of the major epicenters of the pandemic in early 2020. Dr. Breen contracted the virus, ultimately returning to work, but experienced profound exhaustion and stress and wrote to her sister on April 9th that she hadn't slept in a week and, quote, couldn't get out of her chair. Despite efforts at recognition and intervention for her conditions, 17 days later on April 26, 2020, Dr. Breen died by suicide. We have brought dozens of CMOs onto the show since our inception, and many of them are hospital-based and have trained in emergency medicine, but none of our CMO guests have held a position like Dr. Stefanie Simmons, currently the Chief Medical Officer of the Dr. Lorna Breen Heroes Foundation. Dr. Simmons earned both her undergraduate degree and her medical degree, as well as completing her emergency residency training, all at the University of Michigan. And she may need special permission from the state of Ohio to travel across its border, kind of like an interstate visa, but I'll allow it because I went to Ohio State. Regardless, Dr. Simmons has a compelling physician leadership journey, and like so many of us, she has moved away from the bedside patient care to a role in shaping the landscape of healthcare delivery. We're going to hear more about this personal and compelling journey in just a moment, but let me say, Stefanie, it is a true pleasure to host you and welcome to the show.
Thanks, Lee. And I'm looking forward to the conversation despite our disparate origins academically.
It'll all work out in the end, as they say, right?
That's right.
Listen, let's get started with something very basic. You know this show is about physician leadership. And at some point long ago, you began to perhaps recognize you were gravitating towards physician leadership. What was that like for you? How did you get into that awareness of that?
I think I gravitated towards leadership before I knew I was going to be a physician, Lee. I was very fortunate to grow up in Midland, Michigan, which is the headquarter city for Dow Chemical. And part of the benefit of that was they had a lot of youth development opportunities and academic opportunities. So leadership education and training was part of that for middle school and high school students who were sort of identified as having high potential in that area. And so even in high school, I was receiving some training on people management and change management, was a member of the local foundation as a student representative, and viewed my future career through that lens. I actually didn't know I wanted to be a doctor. Like, I'm not one of these people who wanted to be a doctor since I was 5 years old and all of that. I thought I might want to be a history professor. I had applied to medical schools, epidemiology programs, genetic counseling programs, and I was kind of going to let fate decide which path to take me on, and ended up pursuing medicine.
No, I think it is always worthy of exploring how did we get here? And yeah, many of us, I certainly had no idea I would be a physician in high school. That was the farthest thing from my thinking. And if you had said one day you'll be dealing with a pandemic and you'll be in charge of some stuff, no chance. That was not on my radar at all.
Run, walk in the other direction.
Yeah, run. So in the midst of all of this, all right, you become into this awareness, presumably while studying your biology degree at Michigan, that, hey, medicine might be a path for me. And then ultimately you get through all of the training like we all do. How did you then begin to purposefully build a physician leadership toolkit? What were some of the things you put in that box?
Well, so the decision to go into medicine was really about how do I use my talents to help people. And it became clear to me that that was going to be more tactile and recognizable to me in medicine than anywhere else. But what I would say is, even through training, first in medical school and then residency, that was my lens. How can I help people? And as I went through that training, I grew in an awareness that my particular set of awarenesses and talents was really about the interpersonal relationships that fuel medicine. So how do we work with other people to get that job done? So it was during residency, I started to do research on the culture of safety, on patient-physician communication. How do we convey the knowledge that we need to convey to our patients? And actually pitched a fellowship idea for RWJ around patient-physician communication training and interpersonal training. I actually didn't complete that fellowship, matched into it, but didn't complete that fellowship, which is part of my origin story in this professional well-being space. But that sort of was my through line all the way through training. And then I really had this pivot in my sort of personal trajectory at the end of residency that moved me in the direction of patient and clinician experience.
So I have to ask, with that as the background, and we didn't talk about this before, the idea of developing a higher mode of thinking about interpersonal communication, doctor-patient, physician-patient, as well as interprofessional across the teams and at a higher level across healthcare. Why emergency medicine? And I'm an oncologist, right? So I get to spend lots of time with people, God willing, and we wait months for that CAT scan to show an improvement, and we get to know each other. We run into each other, very longitudinal. Why emergency medicine when the encounters are so brief?
You get to have the best conversations in emergency medicine. I'll put us up nose to nose against any other specialties for the types of people we get to talk to, the rawness of the experiences that they're going through, and the depth that we go to quite quickly with people. And I agree, we don't have that longitudinal relationship, although I have taken care of some of the same patients nearly daily for years. So
yes.
But it's really, there's something very special about the emergency department when people are in crisis. They're having the worst day of their life often, whether they know it or not. And you're there in that moment to intervene, to help, to communicate with them, and to do so alongside a dedicated team of talented nurses, techs, clerks, trainees, all pulling together to do that. So the teamwork is extraordinary and the environment's extraordinary.
Yeah, well stated. And I'm sure every specialist we could invite on the show would be able to mirror that, right? In labor and delivery, that something could go wrong in a heartbeat, literally, truly, fetal, maternal. Mm-hmm. And it is the most vulnerable, critical moment in two persons' lives.
That's right.
And so I'm sure all of us can relate to it. But there's something special about that ED flow. And I don't have that. I need that long, slow, oncologic thinking. That's what makes me work. So I'm appreciative of you.
Lee, we all fall in love with our specialties, right? And that's why we're so tribal in some ways. Is that and I probably sounded like I was talking about a boyfriend, right? Like, I was talking about my specialty. I think a lot of people get like that because in the best case scenario, it's a match between you and the environment.
Yeah. Well, we talk about this here with the medical students. You know, sometimes the specialty finds you, and sometimes you find yourself in that flow state. You don't know what time it is. You don't know what time you're supposed to go home, grab something to eat. Then you're probably in a specialty that you're drawn to, as opposed to the one where you're looking at the clock. Like, how do I get out of the OR without screwing up? So,
right.
All right. So you're an emergency room physician. You're leading locally. You're doing your work. And one day you're being asked to partner with your partner company, Envision, and thousands of physicians and leading change and doing work at a very macro level. How did that unfold?
At the very end of residency, I had the case, and many of us have the case in our careers, right? The case that is the most impactful, the most traumatic, that you've experienced. And for me, this was a 3-year-old little girl who came in unresponsive. I had a child the same age at home, and we tried to resuscitate her, could not. I comforted her mother and talked to her, and if that had been the end of the story, it would have just been one of those cases we all carry, right? What's the quote? Every surgeon has a graveyard, right, that they visit. But a few weeks later, I was called to testify in the murder trial of that little girl, and her mother had killed her and was convicted ultimately. And I was so angry, Lee. I was angry for that little girl. I was angry for something that I lost in that experience. You may say it was a naivete, but maybe it was like a faith in people, or a willingness to always assume the best for a while. And the cost of recovery there really, I think, was accelerated by the fact that I was starting to experience some peripartum depression in my second pregnancy with my second child. So I was trying to make a decision about what to do. I was about to apply for my first jobs, get my first real licenses. And at that time, in many state licensing applications and hospital credentialing applications, there was a question, have you ever been diagnosed or treated for a mental health condition? And I made the economic decision not to see a professional for what I was going through because I was worried it would impact my career opportunities. It really it led to a rockier start to my career than it needed to be, and actually ended up dropping out of that prestigious fellowship I had matched into, started working clinically. And it was really 1.5 years, 2 years later that I was at a point where I could really fully re-engage with my career. I started doing work in the culture of safety work for Keystone in Michigan, which was a really comprehensive statewide culture of safety initiative by Peter Provenost and the Michigan Hospital Association. And I was approached by the CMO of our group to become a medical director of quality and safety for the group. And I said, thank you, first of all, for that opportunity. But we don't have anyone looking after the patient and clinician experience of care for our group. This was about 15 years ago.
That interpersonal thing you referred to earlier, right? Nobody oversaw that.
That's right. And shepherded it and developed it in our teams. And so I said, that's what I really want to do. And to his credit, that CMO said to me, we don't have a job description for that, but why don't you write one and we'll talk? Okay. So what a pivotal moment for me. First of all, it was a beautiful career opportunity, but then even in this pivot, that person, right, that CMO gave me the opportunity to innovate and really to create a role that ultimately led, as it developed and grew, to that leadership role in a 26,000 clinician medical group.
So we're going to come back to that in just a second, but I need to share this with the audience and see if you agree or disagree. So thumbs up, thumbs down. So it has been my experience when I was a young, arrogant, that I demanded that there be a hospice house in this town that I'm talking to you from. There was, where I came from in training, there was a beautiful hospice house where patients could be transferred out of the acute care into this beautiful setting and get all the appropriate care. There was none here. I demanded it. And he said, go ahead and bring me back your business plan. Well, darn it, I did. Now, I didn't know what I was doing, but we now have a hospice house. In fact, we have several in town. I also had that experience relative to a cancer program development. And there's two sides to this. Number one, when somebody tells you to go write up a job description or a plan, some of those people are telling you go away because they don't expect you're actually going to do it. And they're kind of asking you to put your money where your mouth is. And some are genuinely interested in your development. They're just not sure how the best way to develop you. The advice I would give, and ask whether you agree or not, if anybody in these positions asks you to do it, do it. You have nothing to lose by returning with that job description or that business plan. Agreed?
Absolutely. And even if that opportunity doesn't ultimately, materialize, right? It doesn't come to fruition. You've still gone through a useful exercise for yourself. And frankly, you've done some visioning for yourself about what you want in your career and your life. And if you don't think it through, it's very unlikely to happen.
That's great. Visioning. We're going to have to put that on our top 10 list. I love that. Okay. So let's come back to, you've got 26,000 physicians. You now have identified something you want to pursue. The company is supporting you. And I think it was at one point in our prior conversation, you talked a lot about change and change management, and you upped your skill set on that. Do you have any words of wisdom around shaping physician change and change management?
Mm-hmm. So there is a science of change management, and we don't often teach it to medical students and residents, right?
We don't.
A little bit. You get some exposure to some lean process engineering, right? And things like that, where you're hearing the voice of the front line and then incorporating them into the planning. That is change management. So we talk about it in quality and safety often and in process improvement, but not often outside of those ideas, and not as a philosophy as opposed to a tactic.
Right.
Right. And so I went to learn outside of medicine. And so very fortunate to have one of the best business schools in the country in my hometown. So I went and did some executive ed. You notice I had to get a little bit of university.
I was hoping we weren't doing that, but go ahead.
I saw you. And so I went and got some continuing education, not continuing medical education, but executive education credits in positive organizational psychology, leading high performing teams, project management, change management. And those skills, you instantly get to practice them when you are learning. And so incorporated those concepts, tried them, was given the latitude to try things that didn't work and have a chance to try again a different way. So in a medical group, right? So our group was contracted with hospitals to staff the emergency departments. you have to become very skilled in leading without authority, because you are trying to influence work environments for your clinicians, but you don't own the work environment, right? And
Right.
so there's a very there's a very specific skill set around communication and stakeholder enrollment and engagement that I developed in the course of leading initiatives in that environment.
Yeah, that is something that many of our partners that run hospitals and clinics are very familiar with, leading through influence without direct lines of authority. And although I do know of instances where people are gaining more and more authority, whether they want to have it or not, but this is just random coincidence. I don't know if this projects well. Have you this? And I'll tell the listeners what I'm showing. I'm showing a book called Inside the Physician Mind. And it was a once in a publication. I don't even think it's in print anymore. And it's called Finding Common Ground with Doctors. That's the subtitle. And one of the things that this book points out, and you're alluding to it in change management, is, well, when I was at the University of Michigan, this is how we learned how to do this. And you get it. Physician training makes you somewhat risk averse, conflict averse. And the idea of change, and it has been shared with me, not my idea, and you must have learned this, that change management is similar to Elizabeth Kubler-Ross's stages of grief. Mm-hmm. You go through denial, anger, bargaining, depression, and acceptance. And it used to be, we thought it was somewhat on a continuum, but it's actually, we kind of cycle through and back and forth. It took me a long time to understand this myself. However, moving physicians off of that base, I trained at, this is how we did it at Pittsburgh, this is how we did it in Cincinnati, and getting them to think differently has got to be one of the hardest things any chief medical officer has to do. Agreed?
Agree. And I would say there is a spectrum of change adversity and risk adversity among healthcare workers and physicians, and that may vary by personality, and personality may vary by specialty a certain amount. And so there may be pockets. I mean, I always think of the change curve, and you've got the bleeding edge and the cutting edge and the early adopters and the early majority as you go through. And so there are going to be people who are more comfortable being in the early adopter group in any department in your organization. And then there are going to be departments that are more comfortable being in that innovation space as well.
Have you used the tactic of identifying the physician champion, early adopter, to help lead that cohort?
Always. I mean, very important step. Not only the early adopter who will then be a spokesperson, but then also identifying the detractor, the person who's going to be like, over my dead body, am I going to start using ultrasound to do my work?
Yeah.
Right. And then enlisting and enrolling that person to win them over, or at least bring them to neutral. Even if you can't win them over, at least bring them to neutral. Both very important. It's interesting. You talked about the stages of grief and the cyclic nature of resistance at times. I like to use the analogy of a sandwich. Everyone's
sorry. We're talking grief and change management. The analogy of a sandwich just makes me want to go get one.
You know what? There you go. So you have a sandwich. It's a sandwich you like. It's your favorite sandwich. Why would you eat a different sandwich? Right? And so there's sort of 3 stages here. The first stage is you have to take the top bread off of the sandwich and look at what's inside, right? And then you have to understand that there are other ingredients out there. You have to switch out the ingredients, and then you have to put the bread back on. And then you can eat the sandwich. So in change management, what does that look like? Well, the first stage is you need to pause. You need to examine your current state, understand what's possible. Do that with all your stakeholders on board, make the change, and then have a resumption of normal activity, right? And if you mark those stages for people, it's actually very anxiety reducing, because they understand what you're doing when and why.
Yeah, love it. I'm going to have to borrow shamelessly, in fact, steal that. That's lovely.
You have to attribute it the first 3 times. After that, it's yours.
Okay, so let's unpack the sandwich, so to speak, and then we'll put it all back together. Many of our listeners probably still do not know what the foundation is. So here you are, the Chief Medical Officer of the Dr. Lorna Breen Heroes Foundation. What exactly is the foundation? And feel free to share whatever is on your mind relative to that.
So I know you shared the story, the origin story of the foundation at the beginning of our conversation. But what happened next after Lorna's death was that the New York Times published an article about her death. And first dozens and then hundreds and ultimately thousands of healthcare workers reached out to share their stories. And they sort of fall into 3 main categories. One main category was there's a lot of us out here who are struggling with either burnout or a mental health condition. And that existed way before the pandemic started. The second sort of set of stories were there are real barriers to seeking mental health care for healthcare workers. There's stigma in healthcare around mental health care and substance use disorder. There's a lack of transparency about what happens if you do get care and how that impacts your licensing and credentialing. And there's a lot of fear. And then the third tranche of sort of questions were the workplace environment could be better. I'm just going to make that as broad as possible to encompass all the different parts of that. And so the foundation was started in the summer of 2020 as a way to take a moment in time where this was part of the national conversation and transform that into a movement to make things better. And so broadly speaking, the Dr. Lorna Breen Heroes Foundation has a mission to improve access to mental health care for healthcare workers and to improve the healthcare system that healthcare workers work within.
And how and when, right? So I'm having PTSD about the summer of 2020. I had responsibilities that barely allowed me to think about anything outside of my command center. And so you're going to have to fast forward. So it was the family that organized around the foundation in that summer. And we're talking, her death is in April. We're talking just a few months later. How did you get personally connected to that? And then what is this role, the CMO of the foundation?
Yeah. So it was Lorna's sister and brother-in-law, Jennifer and Corey Feist, who co-founded the foundation. And this is an important part of how I got connected. So Corey was the CEO of the UVA Medical Group in Charlottesville, Virginia. He was helping to run the medical group. He was the CEO. And he also taught case studies at the UVA Darden School of Business. Okay. So back at the ranch, okay, where I am working to help support the professional well-being needs of 26,000 critical care, intensive care, emergency medicine, and hospice docs. We're, like you said, in a command center, spinning up resources, managing the operative environment to respond to this in the middle of the pandemic. One of the teams that I had developed to support healthcare workers in that role was a team of physician coaches. So these were usually medical directors or regional medical directors who had high EQ, a real desire to help others, and went through and actually got coach training, formal coach training through ICF. And I had a team of 12 of these folks who were doing this work alongside me at Envision. Talented, passionate individuals. One of them was getting his MBA at Darden School of Business and heard the co-founder of the foundation, Corey Feist, speak about professional well-being for healthcare workers. He picked up the phone and said, Steffi, you need to talk to this guy because he talks about this the same way you do. Okay. So it was a connection by one of my team. And so I reached out, and this is August, I think, of 2020. And I said, hi. And by the way, how I reached out was a cold DM over LinkedIn. So sometimes that actually is a way to connect with people.
Shocking. This just in, Sanjay Gupta is going to report on this tonight. I do believe that is how I reached you. So thank you for responding.
That is how we were connected. And so he was very generous, and we had a phone call. We ended up talking, I think, for 2 hours, that first call. And I said, this is what I do professionally. I lead this for a large organization. Put me in, coach. Like, how can I be of service to what you're starting here? And so we partnered on a couple of different projects, did some educational materials about physician suicide, podcast, webinar together. And I joined the board of the foundation, and I was on the board when my organization became aware of the foundation and realized that there were some real congruencies in how we looked at the world. They were very generous in allowing me to spend part of my time as a partial CMO of the foundation. And then ultimately, a year and a half ago, I left and became the full-time chief medical officer.
Okay, wait. So I'm calling a timeout on the field. All right. You're having these conversations. You're shared visioning of what you could bring to the table. You're on the board. Is there a CMO before you make that phone call?
No.
Okay. So did you and Corey and others create this role?
Yes.
Okay. And so what exactly do you do in this role? Or what are the key responsibilities, one or two key responsibilities, right? Because I know you're not managing the medical staff, so what are you doing?
That's right. So, I mean, if you just break it down into the 3 words, right? So chief, I co-run the foundation with our CEO and president and our chief experience officer. So we are the executive team for the organization. Medical. Okay. So I am bringing my expertise as a physician, but also as a physician leader who ran this work for decades. And I'm also bringing the critical research and eye to data as we're bringing in data, analyzing it, and helping to plan our strategy. The area that I am most involved with in the operations of the foundation is our sort of acceleration of solution adoption. So earlier this year, I was at a conference which was largely about healthcare IT startups, not my typical milieu. And I kept being challenged to describe what the foundation does, but in a way that people would understand. And so I said, we're a translational research startup that accelerates adoption of best practices in the hospital setting. Okay. So if you look at it that way, what I'm doing is really serving as the translator of how do you get best practices around professional well-being adopted in hospital and healthcare settings in a way that honors the existing work of the hospital and healthcare, honors the resource-limited nature of what's happening, and also assists the ongoing work of the people who are leading this area.
So I love this, and I'm glad that we did not rehearse this. For the listener's sake, we did not rehearse this because I didn't understand it, and I specifically waited until we got to the show. One of the things that we think about amongst the CMO peer group that I'm in is to be the doctor's doctor. Mm-hmm. When we trained, that was usually the provenance of the pathologist who used to think that, they were going to tell you everything you needed to know. They were the doctor's doctor. Well, life has changed, but chief medical officers have the chiefness, meaning that connection to the C-suite, governance and management and operations and all of those things that we don't learn in medical school, but we're physicians. So I don't care. You could be a chief physician officer. You could be the chief clinical officer, chief medical officer. We understand what it's like to be in the room as the physician. Very few other people will, I mean, you and I can go off and do other careers, but not a lot of people at our age can show up and become a physician at our age. It can be done, but it's easier said than done. So now I understand you are that universal translator. And if you haven't had the opportunity, this show represents a great outlet for you to be sharing with thousands of chief medical officers that there's a chief medical officer in the world of mental health advocacy, shaping and changing the way we approach it in the physician universe. And so indirectly, you might shape a medical staff somewhere. And I am very much appreciative of this role and what you do. And I'll repeat this anytime somebody asks, what do you do? So is that fair? Did I frame that right? Reframe that back to you right?
No, you got it exactly right. And what is interesting is that, I mean, what do we say as physicians? You don't really get it until you walked a mile in my scrubs, right? Or in my increasingly battered clogs, whatever, whatever you want to say. But there are universal truths that are human. And there are specific experiences to being in healthcare and even more specific experiences to being a physician.
Yeah. No, unless you were in that room with that mother and that child. But every other physician has had that story of their own that they carry with them forever. And the non-physicians, maybe the nurses and our other team members have those stories. But if you're not in medicine, you don't have that story. First responders have it. Generally, most other people do not. Okay. All right. So you are no longer in the emergency department, right? You're no longer taking shifts. And I'm curious because a lot of us in our roles have gone through this. And I'd like to hear what that has been like for you, your identity, what happens internally. How has that manifested for you in life to no longer be at that acute moment of someone's most immediate vulnerability, and you're not doing that anymore?
Yeah. The common question that I get is, do you miss working clinically? And the answer I give is, I really miss a good shoulder reduction. Because someone comes in and they've got a problem that you can see, feel, and touch. And then you apply your unique set of knowledge and experiences. And when they leave, they don't have that. That doesn't happen in 15 minutes anymore.
Right. Right.
You know, the time scale of the impact has increased to like 15 weeks, 15 months, 15 years. In terms of seeing that impact, the decision was the hardest decision I've made in my life to step away from clinical practice. It happened before this role. So my last shift was October 19th, 2019. Obviously impactful, given that I remembered the date. I actually didn't know that I remembered the date until I just said it. I remember my last patient was a wonderful retired nurse with appendicitis. Great case to go out on. The decision was a hard-fought decision that happened over years. And for me, it was multifactorial. So I thought to myself, what am I here to do? I'm here to use my unique set of talents to make a difference for people. Where do I do that best? And for a long time, the answer was in the emergency department. But as my ability to have impact expanded, and my skill set became specialized in that leadership area, that was no longer a true answer. And I also realized that particularly when I'm talking about healthcare workforce well-being and professional longevity, I needed to walk the talk. And I was at the point where between my full-time job as the VP of Patient and Clinician Experience at that point, And my full-time job as the mother of 3 children and my part-time job of emergency medicine, I wasn't particularly walking the talk in terms of that life balance and time to relax and recuperate and re-energize. I also was down to super part-time clinically and felt like I was on the verge of not being the quickest that I could always be in my career. And the last thing I ever wanted to do was to not be my very best for a patient in front of me. And so that more than anything, I think made the decision for me. Okay, I'm being pulled in a lot of directions here. Maybe it's time to focus in on this one area. And keep in mind, I grew up saying specialization is for insects. So like it was a it was a really hard thing for me to say. I need to specialize now.
Yeah.
It's broad. But I got to that point.
Yeah. This could easily be an entire episode on. So this is the most common question that we get, this group that I'm referring to. Should I or should I not continue to practice medicine? And of course, to your point, we have tribes, we have different disciplines. As an oncologist, yeah, it's easy for me to get into administration because it takes a year to get anything done, right? So I'm 6 months at best. An obstetrician is well suited, takes 9 months to see that baby. But in emergency medicine, you are used to quick results. And so we have our tendencies, we have our tribes, we have our specialties, and some of us are already pre-equipped for the administrative timelines. And sometimes that work in practice is a detraction to being 100% administrative. I'm using that term broadly versus being less than 100%. And so when health systems seek to employ chief medical officers, oh, you're going to be a 0.6 FTE. I said, what is that? I'm a 1. I'm either a doctor or I'm an administrator or I'm a 2 FTE. Like, pay me twice because I can't do half the job that you're asking me to do without doing it full time. So we have learned, and I have personally learned, that it really depends, and you were alluding to it earlier, where an individual is on the spectrum, who they are as a person, what their specialty is. Some physicians are in smaller hospitals where they can do half clinical life and half professional administrative life. But in a bigger system, don't try to be a 2, 2.5, 2.8 FTE. Don't do that. And come to terms with it and decide. And as you alluded to, it's extremely personal what you will ultimately. I can't make that decision for you. You can't make that decision for somebody else. But you have to go through that exercise like we talked about the job description. Okay, if I'm going to take this role, what does that mean? What's the vision for this responsibility and how much can I keep on my plate? So I appreciate you sharing that answer. Does it ever feel like you go through moments of grief relative to giving up clinical medicine?
Absolutely. Although earlier on, it's been 6 years. So earlier on, I think that was more common for me. As teenage daughters are wont to do, mine really pointed out to me this feeling. And one of my girls said, "Are you even a doctor anymore?" And so my initial response was like anger. And what's that about? So I started thinking like, okay, why am I angry about this? And I was like, because I am doing that. And so I was also forced to articulate to someone who doesn't know the nuance of our profession how I was using everything that I've learned up until now in my current role. And that, yes, I'm a doctor and I am actually still doctoring. I may not be reducing the shoulder of the patient in front of me, but I am doctoring the system and doctoring the doctors and the nurses and the pharmacists and the techs and the clerks, right? The healthcare system to be a more effective, efficient place for those human interactions to occur.
Yes. Thank you for sharing that. And that probably brings us to our last question. And it's a two-sided question. I'm curious about your thoughts on physician advocacy and sort of suggestions you might make. By and large, the House of Medicine is going through this massive disruption, and most physicians want to be focused on patient care, and they just tend to stay out of the advocacy world, and whether or not you think that may change or ought to change. So that's comment one. How do you feel about general physician advocacy? And two, for our specific listeners, many of whom are chief medical officers in health systems, how might they take what you are describing to us and shape and help transform the awareness and the changes that could occur around physician well-being and those who happen to have mental health issues? How might they do that? So one, advocacy, and how might CMOs take advantage of what we're talking about?
Okay. So I'll start with advocacy. If you had told me 10 years ago that I would be regularly testifying in state and national legislature and advocating for passage of specific bills, and that would be like a significant part of my life, I would have laughed and walked away. Okay, so I'll just start there. This was not ever something that I was interested in for its own sake. For me, the advocacy portion of what I do now came because I cared deeply about something and wanted to change it. I suspect for many of your listeners, that is actually why they are or want to become a CMO, because they care deeply about something and want to change it. And you start to say, okay, what are the components of changing this? There's the stuff that happens between your own ears first, right? Like, what do I need to learn, know, and do? And then there's your local environment. How can I change the team around me? How can I do this for my unit? How can I do this for my hospital? How can I do this for my health system? And then you're at the brick walls of your institution, and change still needs to happen. And that's when you become an advocate, right? When you say, okay, well, things need to change in the city, in the state, in the nation for what I care about, to make what I want to happen for my patients happen.
So one of my first guests and who helped me originate the show, we spent some time, and his declaration was, if you want to go be happy in life, go sell ice cream. This job, the CMO, could be called the change management office. And all CMOs, when they find their passion, and maybe there are some who are listening right now going, I've got to do something, you have to be the change agent at your institution relative to this topic. Now, next year might be a different topic. So what I'm hearing you say is if this aligns with who you are and where you are and what you can do in your institution, go for it. And you recognize not everybody is into it, so be it. They'll find the other thing, correct?
That's right. And it really does. It's as simple as building a relationship with your representative, becoming a trusted partner, and talking to them about the things you care about.
I think you answered both questions right then and there. And I'm going to wrap up with you and tell our listeners, I would say, guys and girls, if this is something that you feel strongly about, please connect with Dr. Simmons. Please connect with the foundation. There are resources, there are tools, there are things you can learn. And if this isn't your thing, maybe use this as a launching pad for something else you want to change where you are. Please add to that.
So if you're looking for something tactical and achievable that you can change to impact healthcare worker well-being at your organization in the next 6 months, you can audit your credentialing applications and peer reference forms, remove stigmatizing language about mental health from them, and communicate that change to your healthcare workforce. We have a toolkit, and we provide free technical assistance on that. About 1/10 of the hospitals in the country have already made the change, and it's been endorsed by all the major healthcare organizations and accreditors. So
love that. That's beautiful. Everybody, we've got some resources for you, and it's being offered by Dr. Simmons and the foundation. So please take advantage of that. Any other last parting shots at the state of Ohio or descriptions of your favorite sandwich before we go? Anything for our listeners at all?
If you want to change the professional well-being of the healthcare workforce, you need to remember not to forget yourself in that equation. So make sure to start with you, and you can't give what you don't have. So take care of yourself, and that will help you be a better leader for your teams and for your organization.
Well stated. Okay, well, that's been a great show. Absolutely amazing. And for all of you listeners, you have been listening to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. And today it is also dedicated to Dr. Lorna Breen and the folks who carry on in her memory. Check out the Dr. Lorna Breen Heroes Foundation on the internet. Support the work that Dr. Simmons and I have been talking about, and support what the family is also doing to shape healthcare in the coming decades. Connect with them like you connect with the show. And remember, as we always say at the end of the show, in the words of Sergeant Phil Esterhaus, let's be careful out there.